This is a rehab plan for our patient with a left posterior hip dislocation with a labral tear. He is a 35-year-old male. He is a manager at HEB and an active father of his children. He coaches his daughter's soccer team, and he is very involved in his 5-year-old son's Boy Scout troop activities. He also enjoys running 3 mornings per week with his wife.
So our patient's injury presented with an internally adducted flexi in this photo, and he was in a car accident. Head-on collisions are the most often mechanisms of injury for posterior hip dislocations, and he remained in the hospital for 3 days after surgery, and all of his neuro examinations were normal. Oftentimes the sciatic nerve can be involved, as well as other surrounding structures within the hip joint capsule, and we will go over this in the next slide.
These are some of the involved structures of the posterior dislocation. As you can see, the ligaments, the acetabulum, and the labrum, as well as some of the capsular tissue. And the sciatic nerve is also a main structure that's at risk in these posterior dislocations. Some concerns we have with this injury are decreased mobility. These are primarily due to adhesions that may have developed while he was immobilized right after his injury. We would also be concerned with atrophy of muscles in his lower leg, and also any compensation that he may have due to his injury during his gait and other phases of movement. Some precautions that we have is to make sure the patient does not cross their legs. They cannot sit in a chair with their hip at 90 degrees or greater, and they cannot bend forward at the waist, and these should be avoided for at least 12 weeks after the injury. Some long-term complications that we want to make our patient aware of are avascular necrosis, post-traumatic arthritis, and redislocation.
So we chose the surgical treatment because it was necessary in order to repair the labral tear. When appropriate, hip arthroscopy is preferred over open surgery because of its minimally invasive nature, the lower risk of avascular necrosis, and the faster recovery time.
So for phase 1, our goals are to decrease pain, of course increase range of motion and flexion. These will be passive, of course. Also, we want to prevent that atrophy of his muscles in his lower leg, and definitely we want to break up any adhesions that he had gotten while he was immobilized. Some of the exercises are listed here, and we will also now demonstrate the passive pendulums for range of motion of the hip.
Pendulums for the hip are performed by having the patient lay on their back on an elevated surface, and the clinician or caregiver standing beside the affected limb, and creates a backward and forward sawing motion with their arms throughout an arc of 30 to 70 degrees of hip flexion for 20 minutes, 3 times a day. For phase 2, which is complete in weeks 4 through 8, preventing gait abnormalities due to compensations, gaining pelvic control, and increasing strength of the quads, hamstrings, and abductors from 3 out of 5 to 5 out of 5 is important in order to progress to more difficult exercises in later phases. We're also going to focus on increasing balance and coordination, which are important to proprioceptive exercises, and we're going to try to become full weight bearing by week 6. So these are some of the phase 2 exercises, and now we will demonstrate a few of those for you. Hip extension exercises with a resistance band can be performed with the patient standing up, holding on to a nearby object for stability, and extending their leg backwards against the resistance band, without bending at the hips and keeping their chest up. A mini squat is performed by standing with your feet shoulder width apart, keeping your weight in your heels, and pretending as if you're going to sit in a chair. 30 to 45 degrees of knee flexion is all that is necessary to perform this exercise. Heel slides are performed by having the patient lay on an elevated surface on their back. The unaffected limb is kept straight as the affected limb bends at the knee to approximately 70 degrees, so as not to bend the knee past 90 degrees, which would be premature for this stage in rehab.
For phase 3, some of our goals will be to gain full muscle strength in hip abduction and extension by week 10. These are important for stability of the hip. We also want to increase our proprioceptive abilities and increase them from uniplanar to multiplanar. We're going to start performing some functional activities and making sure our patient has proper technique. And we're going to start being able to walk longer distances. We also want to make sure that we're still maintaining our range of motion and flexibility while we gain these strengths and endurances. These are a few of the exercises that we will be doing in this phase, and now we will demonstrate the sit to stands.
Sit to stands are performed standing with your feet shoulder width apart and keeping your weight in your heels as you sit down in the chair. As you rise, keep your chest up, extend your knees, and bring your bottom forward. So some of our phase 4 goals were for our patient to be able to get back to doing his normal activities of daily living that he enjoys, his hobbies with his work, and with his kids. So being able to climb 3 flights of stairs with ease and proper gait is an appropriate goal for his occupation. Being able to jog 3 miles and then run 3 miles is appropriate for him to be able to become active again with his wife. So these are some of the phase 4 exercises. Today we'll be demonstrating split squats, and most of these exercises can be progressed by either increasing the distance jumped, the height jumped, the intensity with which it's performed, or the length of time with which it's performed, being a shorter time than a longer time, in order to increase agility and efficiency in his activities. Split squats are performed by standing up, going in a lunge position, and then jumping from one lunge position to the other in an alternating motion. Make sure to keep your arms moving so as to gain enough power in order to make it all the way to the opposite lunge motion without tripping or falling.
So some of the major differences between surgical and non-surgical treatment of the posterior dislocated hip are that the non-operative focuses mainly on strength and stability of the hip joint, and this is usually the preferred method if there are not a lot of other issues with his dislocation injury. The operative treatment is the treatment that we choose when there are loose fragments, labral tears, or anything else in the way in the joint cavity that leads to an unsmooth surface for the joint to move around.